Good morning, everyone. Thank you all for coming to the first seminar of the Sagol Center for Regenerative Biotechnology. As many of you may know, the center was established last year with the generous help of Tova and Sami Sagol. Thank you, Sami, for that. We still don't have a physical space, but in the next few months, they will start building the new nanoscience building in the university, and we will have nice facilities over there. So hopefully, in a few years, we'll be able to move over there. I would like to also thank Precise Bio and Arya Bat for sponsoring this event. And without further ado, I would like to introduce Professor Tony Atala. Thank you, Tony, for coming. So Professor Tony Atala heads the Wake Forest Institute for Regenerative Medicine. It is one of the biggest regenerative medicine institutes in the world, perhaps the largest, with more than 400 researchers working on tissue engineering and regenerative medicine. His work focuses on growing and printing organs. Over 14 of his technologies were already in the clinic. He's the editor-in-chief of 3 journals and 20 books, has published over 600 papers, received over 250 patents. Professor Atala was elected to the Institute of Medicine of the National Academies of Science in 2011 and to the National Academy of Inventors in 2013. He's a recipient of many, many awards, including the US Congress-funded Columbus Foundation Award, the World Technology Award, and the Edison Medical Science Award. On a personal note, I heard of Tony's work when I was an undergraduate student, and I took the course of tissue engineering, and I learned about the amazing work that he's done back then when he was a professor at Harvard. And now when I teach the course here at Tel Aviv University, I always mention to the students about the successful stories of his products and the amazing work that is done in the institute. And thank you, Tony, for coming. It's a great pleasure, and looking forward to hear your talk. Thank you.
Thank you so much, Tal. What a pleasure to be here with you, and thank you for the invitation. And just really enjoyed interacting together. Thank you so much for having me. And you're doing such great work here. And also, I understand that we have major visionaries behind the work going on here in Israel, and specifically Tel Aviv University with Mr. Sagol here and Mr. Khan, who's also supporting these areas. So, it's wonderful to be in a place where you have so many visionary people supporting the area. So I want to acknowledge your contributions, and thank you as well, Arya, for having me here in Israel through Precise Bio. It's a pleasure to be here. Interestingly, I have many friends here with Precise Bio, but also from Boston. There's a young lady here, Rachel Kornetsky, who's in veterinary school, who actually comes from Boston. So, and I've known her for many years through her family, through my days at Children's Hospital. So it's great to be among friends here at this wonderful place. I have to tell you that the whole week coming up to here, my wife kept saying, "I wish I could go with you," because she just loves Israel. So I wish she could have been here with me today as well. But I'm only here for one day, actually. So what I thought I would do today is really give you an overview of regenerative medicine and some of the work that we're doing here at the Institute in North Carolina. This is actually a picture of our institute. Like Tal mentioned, we do have over 400 people working together to bring these technologies from the bench to the bedside. And my colleague Shai Socker's here with me, who you're going to hear from later, who's been with me for many, many years, almost from the beginning of the Institute and our work in Boston. This is actually a painting that hangs at the Conway Library at Harvard Medical School. And it shows the very first time an organ was transplanted, and this was back in 1954, and the organ was a kidney. And you see Harwell Harris in the back room retrieving the organ, and in the front you see Joe Mary getting ready to implant the very first organ in a patient. And so many lives that have been saved by transplantation, but we're still dealing with challenges in terms of shortage and organ rejection. And that's where regenerative medicine comes in, of course. We can use cells, scaffolds together, or the other bucket we call enabling technologies. And I'd like to describe to you each of these buckets today. In terms of regenerative medicine, though, it's not a new field. Interestingly, the concept of regenerative medicine dates back to the 1930s. There's a book that was published by Alexis Carrel and Charles Lindbergh back in the 1930s, and the first actual clinical application of these technologies dates back to 1981, when a patient with a burn at the Mass General Hospital in Boston had a small piece of skin taken, the cells were expanded, they were placed in a piece of gauze, if you will, material, and the cells were placed over the wound. Now, it didn't make new skin, but they did show that the cells could improve the healing of that patient, and that was back in 1981. So the field's been around for so long, why so few clinical advances? And that really has to do with major challenges in the field. The first challenge was the inability to expand cells outside the body in large quantities. The second was inadequate biomaterials and vascularity, and we'll discuss each of these three topics. The first was getting cells to grow. The fact is that just 30 years ago, just 3 decades ago, in the 1990s, early 1990s, most human cells could not be grown or expanded outside the body. That was just in the 1990s. So a lot of the work that we did early on was really growth factor biology. We're very lucky to be in Boston. Our floor mate was Judah Fogman, who was the founder of Field Angiogenesis, who has been working with one of your investigators here, who's printing tumors. And basically, this area of growing tumor cells was interesting, but the question was, how can you grow normal cells? And that's really what we were looking at, how to grow normal cells. And this is a piece of bladder tissue, and what we found was that the cells that you needed to grow the actual tissue were the cells here that people were throwing away. So in reality, what we needed were the baby cells that could crawl and cry, but people were looking for the adult cells that would walk and talk. And so people were throwing away these cells down here, but these were the cells, in fact, that actually were the progenitor cells, what we now call progenitor cells, that would give rise to new tissue at the time of wound healing. So by isolating these cells in the right location, and by using the right growth factors, we can now take this cell type that could not be grown or expanded, and now we could. We could now take a very simple piece of tissue less than half the size of a postage stamp, and by day 60, we have enough cells to cover a football field. So if we fast forward now to 2019, most human cell types can now be grown and expanded outside the body. But even now, believe it or not, there's still several types that cannot be expanded in large quantities outside the body. And those are listed here: liver, pancreas, and nerve. Even now, we still can't get this done. So there's still a lot of work that needs to be done in cell biology to get these cells to expand outside the body. The second challenge was biomaterials. How do you actually get these cells inside the body? And we basically adhere to a lot of the very simple principles that you know of today. The materials had to be biocompatible. They needed to have a low inflammatory response. But the major area that we focused on, this is about 3 decades ago, was that the scaffold should replicate the biomechanical and structural properties of a tissue being replaced. That is, if we're trying to replace a piece of bone, of course you're going to use a very different material than if you're trying to replace a blood vessel. And the third challenge was vascularity, and I already mentioned Judah Fogman. He basically, in 1971, had established this very simple principle that cells could not survive in volumes larger than 0.3 millimeters. That's about the size of a pinhead. So that's about it. That's about how large the tissue can be to survive before it needs blood vessels. Anything larger, you need blood vessels to feed it. So this is a challenge because now we can grow cells that can cover a football field, but we can only implant cells about the size of a pinhead. So how does nature solve this problem? And nature solves this problem by branching. From the lowest forms of life, such as algae, which you may find at the bottom of the ocean floor, to an individual leaf, to the branches of a tree, to the vascular branches of the body. Branching is a solution to nutrient diffusion. And that is why we started working with materials that to the naked eye would look like a piece of your shirt or your blouse. But in the microscope, it had this branching pattern, which would allow the cells to lay down and allow new blood vessels to grow into the sporous structures to enhance vascularity. Very early on, we actually recruited Shai Salker from Judah Folkman's lab. And Shai was the only person in Judah Folkman's lab who was working on actually making cells grow as opposed to making them not grow, right? Because with a tumor, you're trying to starve the vascularity. So we quickly brought in Shai to our team to work on vascularity, and this is actually some of the work that Shai ended up doing. We're basically implanted muscle cells in the back of a mouse, and you could see that if you implant the muscle cells alone, nothing much would happen. If you added endothelial cells, which are the cells that line blood vessels, you had a little bit better, but not much vascularity. If we added the most potent growth factor, VEGF, you really did have a nice vascularity, but there is no doubt that if you had all the ingredients necessary, muscle cells plus the growth factors plus the endothelial cells, you could now really create the tissue. So vascularity was key. And also the ingredients are key to make sure that these technologies work. So one of the first tissues that we targeted was the urethra. That's a channel that connects the bladder to the outside of the body. And basically we started playing with materials first, materials alone without the cells or with the cells. And this is a rabbit study where we excised a 1 centimeter segment of the urethra. This tubular structure can be very long, can be up to 20 centimeters in a patient. But this is in a rabbit model. We excised a 1 centimeter segment, and we then took a matrix that we took from bladder, and we washed the cells away from the bladder, just leaving the extracellular matrix, which is mostly collagen. And we then tubularized that structure with or without cells. And what we found was that if we used the cells, it regenerated the tissue. But if we didn't use the cells, it only did so for a limited distance. 1 centimeter was the maximum distance which cells would regenerate without starting to have a stricture or scar. So about half a centimeter from any edge. So about 6 years later, we ended up doing patients where we used the scaffold alone without the cells. And here's a patient who had a urethral injury, and you can clearly see the area of the injury where it's not entirely tubular. But this is about 4.5 centimeters. But I just told you that if you use a scaffold alone, the maximum distance is half a centimeter from any edge. So how did we do that? Well, if you look at this, it's like a tunnel, and it's only the top of the tunnel that was injured, which means that the distance between the normal portion of the tunnel and the central portion of the normal tunnel was about half a centimeter from any edge. So by having this distance, we were able then to place a material on the top only, replacing the top of the tunnel, and observe this rule where you could use the material alone without the cells, and this led to the full regeneration of this organ, using the material alone without the cells. But remember, this only works for areas that are less than half a centimeter from any edge, and you can see here the normal tissue that was formed. And you can see here endoscopically in this patient, you can see the area of the stricture and the narrowing on the left, and you can see the tubular normal area on the right that had been regenerated. And so the cells themselves walked on that bridge and bridged the gap. So that's how the technology works. You put that scaffold in, the cells from the periphery walk on that bridge, they replace the bridge, and the material that we put in starts to degrade. So 6 months later, that material is fully gone. So what happens during that time? During that time period, what happens is that the cells sense that their bridge is giving way, and they start to build their own bridge. So 6 months later, you end up with the patient's own cells and the patient's own bridge. Now, what about longer defects that cannot be fixed without this half a centimeter rule? Well, here's a patient had a very complex injury, and you can see here the area of the injury clearly between the bladder and the urethra, and you can see the delineation of the prostate there through the X-ray. So you have a long channel to replace. This is clearly more than half a centimeter from any edge, and you don't have a bridge upon which to build another bridge. So the concept here is you have to use the cells. So the strategy is we go to the patient, we take a very small piece of tissue, less than half the size of a postage stamp, we expand the cells outside the body, we then take the scaffold in the shape of a tube, we coat the outside with the muscle cells, the inside with the urethral epithelial cells, we let it mature in an incubator, and we then put it back into the patient. The whole process takes about 4 to 6 weeks, depending on the organ we're targeting. So here's the patient's X-ray on the left. Here's a tubular structure in the center without the cells, just a scaffold alone, made of polyglycolic acid and polylactic acid. And then on the far right, you see the engineered structure fully coated, fully seated with the cells after it comes out of the bioreactor. This gets implanted surgically, as you see here in the second panel. And on the third panel, you see the fully regenerated urethra that was placed in this patient. And this is from an X-ray 6 years after surgery. Basically, we published that work in The Lancet in 2011. And by the time we published the work, we did have the 6-year follow-up. This shows a pilot study with all the patients in the series, showing you the area of the injury on the top panel, showing you the earliest X-rays 3 months after surgery, and the latest X-rays up to 6 years after surgery. But more important was how did these patients do with their flow? They did very well over the period of time, and they continue to do well today. So we now have over a 20-year follow-up using the scaffolds alone without the cells for minor defects, small defects, and this has been applied now literally to tens of millions of patients for many, many different indications in orthopedic surgery and other plastic surgery and other areas. And we have over a 10-year follow-up using scaffolds with cells for large defect repairs, as I just showed. We then started to apply these technologies to other structures, for example, blood vessels. Same strategy here. We're going to use blood vessel cells to regenerate the tissue. So we take, instead of taking urethral cells, we're going to take endothelial cells that cover blood vessels. We're going to take smooth muscle cells from the vasculature to create these three-dimensional structures. And we then started to build these bioreactors. And this is back in the 1990s. And basically in the 1990s, really you couldn't, we couldn't create these structures without them collapsing. We would create them in the laboratory, but they would collapse and they wouldn't do very well. So that's when we realized we really needed to condition these structures. And we just basically, at Children's Hospital Boston, we got in touch with our mechanical engineering department, and we talked to them and said, these are the people that fix all the machines in the hospital. And we said, we need something that's going to, create that we can flow stuff through. So they built these bioreactors for us in the 1990s. And these bioreactors basically allowed us to exercise these structures before we implanted them. And by exercising them, we were able to condition them. And this is a carotid artery that was replaced using these techniques. And you can see here in a preclinical model, we published that work in Nature Medicine. And now this has been done now in terms of actually creating engineered blood vessels by many investigators, and this has been in numerous clinical trials that are currently ongoing using various strategies. So blood vessels are now being implanted in patients. Now this is a heart valve, and same strategy here. These have not been implanted in patients yet, actually, but just to show you these bioreactors and how we create these bioreactors to really condition, again, the cells to do what they need to do. You can see the heart valve leaflets opening and closing here. And again, the conditioning of these vessels allows for the flow-dependent endothelial layering and the partial maturing of these structures before you put them into patients. Now, our latest strategy that we've been working on for the last 10 years or so, and we're launching into the clinic this year, is this strategy of actually allowing the body to regenerate itself. And you can do this with a vascular system, because through the vascular system, about your whole blood flow heart volume goes through your heart every minute, basically. So you have about 3 liters of blood, and those 3 liters of blood go through your heart every minute. 60 beats per minute, you're creating this flow. And so it's the ultimate bioreactor, right? It's the ultimate bioreactor. So the way that we do this is, instead of actually growing and expanding the cells outside the body, we use the same protein that we use to isolate the progenitor cells from the blood. So to create the blood vessels, what we were doing is we're taking 10 cc's of blood, harvesting the progenitor cells, expanding the progenitor cells, and then seeding them. So the strategy here is, why don't we just put the protein on the structure itself. So we create the scaffold, the heart valve scaffold. We adhere the protein that attracts the progenitor cells, and basically allow this heart valve to develop inside the patient. And that's what happens. And over a 3-month period, you basically have a fully engineered heart valve in the patient. As you know, right now, the options for a heart valve is to have a mechanical heart valve that's made out of metal, that'll last forever. Or you have these heart valves which are derived from either pigs or cows or cattle, bovine heart valves, and these are basically cross-linked and then placed in the patient, but they only last about 10 years because they give out. They don't have any tissue behind it. So the goal here is to actually adhere this protein over 3 months. You have now a fully engineered heart valve, but the body is the one that attracted these stem cells, these progenitor cells, to create the valve. Over a 3-month period, you now have a fully seeded valve that is like a porcine or a bovine valve, but now it's going to last because it has the tissue behind it. Now, we've talked about flat structures such as skin. We've spoken about tubular structures such as blood vessels. There's a level of complexity there. Flat structures are the least complex. Now, they're all complex, but flat structures are the least complex. Tubular structures are the second level of complexity because you have more at risk. Hollow non-tubular structures are the third level of complexity because the cells are more complex, the architecture is more complex, there's more interaction with other organs. Same challenge here. We could not get these cells to grow and expand outside the body. And so we went through the same process of basically spending a couple of years looking at the cell biology so we could really get these cells to expand and make sure that these cells retain their properties over time. Once we were able to isolate these committed progenitor cells and expand them using the same criteria, we were then able to start matching these with different materials. So I'm going to take you through the steps of how we engineer these tissues. First is the cell biology. And the cell biology, I have to say, is the most important because the cell material that you're going to use is the material that's going to form your tissue, and you have to make sure that they're the same cells time and time again, which is easier said than done. The second challenge is to make sure you have the right materials and have the right properties. So what we do is we reverse engineer. We take biopsies, small tissue samples from patients who've had surgery, and we take samples from all ages. And we then look at the biomechanical properties of a tissue. And we then reverse engineer by using materials that are going to replicate the biomechanical and structural properties of the tissue. Once we have these materials, and we have a family of over 40 of these materials, all degradable. There's one thing in common with all these materials. They're all fully degradable. They all go away. So by the time 6 months later, you're left with the patient's own tissue, as I described earlier. So once we have the right cells and the right materials, we then do our animals in mice, our studies in mice. We take the cells from humans, we expand them, we put them on the scaffolds, and we put them in the back of a mouse model to show that this really can reconstitute. And you can see here how by 4 weeks you have full layering. We're just placing cells on one side and the other side, and of course these are very porous materials, so the cells are going to be all over the center, but there's a self-assembly that occurs, and by 4 weeks all the epithelial cells are on one side, all the muscle cells are on the other, and you can see the generous angiogenesis and neovascularity, the new blood vessels that have come in to feed this structure before it's formed. And that's exactly what happens is the cells will not keep layering until the right blood vessel supply is in place. And that's how the technology works. Once we know that it works in a mouse model, in the back of a mouse, we then go to a rabbit model, and now we're going to do in the rabbit basically we do a partial replacement in a rabbit model to make sure that we can achieve the partial replacement. And once we're able to achieve a partial replacement to make sure that we have the right conditions, we then go for a full replacement. So now we're going to do in the rabbit what we would do in a human. We take a small biopsy of the organ, we grow and expand the cells, we create the construct, and we put it right back into the rabbit. But now we know that the full organ has to come from the cells that you put in, right? It's black and white. It either works or it doesn't. And that's really your acid test to make sure that you can create these structures. Now, again, we use these bioreactors to make sure they have the right conditions. And here are some of the x-rays in the animal model showing that if we don't use the cells, of course, this is much larger than half a centimeter from any edge, so it's not going to form. It's not going to develop. But if we do use the cells and the scaffolds together, then you have the organ that appears normal radiographically, but more important, it appears normal grossly. This is at the time of retrieval of the organ. You can see the formation of the organ so that by 6 months it's fully formed. And you can see at 1 month it's not yet fully formed. So the body is completing the process, right? So at 1 month it's not, you can still see through this thin muscle to the scaffold itself. But by 3 months it's fully formed. By 6 months the scaffold's fully gone, and the cells themselves lay down their own scaffold, their own bridge, so you end up with the patient's own cells. And here in the animal model, you see on the far left what happens if you don't use the cells. It just resorbs over time. When we look at the collagen content, the epithelial phenotype, and the muscle phenotype, it approximates the normal organ by 6 months. When we look at the molecular analysis, looking at genes and proteins, it approximates the normal organ by 6 months. When we look at the collagen deposition and the elastin, now this is the bridge that the body itself laid down after the material is gone. And again, the bridge approximates the normal extracellular matrix at 6 months. And when we look at the tensile stress and strain, the ability of these organs to be elastic and coapt, they again approximate the normal organ by 6 months. And when we look at the innervation, the nerves, it again approximates the normal organ by 6 months. And nerves come in very much in the same manner as a vasculature. You can see in real time, time-lapse histology, how the nerves start coming in parallel to the vascularity enhanced by the scaffold system that we put in. And we actually test innervation very extensively because, as you can imagine, the nerve endings for all of these organs is very important. So what we do is we take small biopsies, small tissue samples from the structure, engineered organ, from these engineered structures that have been implanted. We take them out of the body, and we then test them in vitro in the laboratory setting, where we can see that the innervation is truly in the tissue itself, that the nerve endings that we see are coming from the tissue we implanted, and the response we're seeing is not from the peripheral tissue, showing that the innervation is indeed present and approximates that of a normal organ by 6 months. And we then went to our human clinical trials. These are patients, human patients, who were born with the Mayer-Rokitansky syndrome, which is a syndrome where the organ does not develop. They do have a rudimentary structure, so we're able to take a very small tissue sample from that rudimentary structure, and we're then able to expand those cells outside the body. We create the construct in the same manner. We coat the outside with the smooth muscle cells. We coat the inside with the epithelial cells, put it in the bioreactor, and you can see here on the right, you can see the actual rectum. On the left, you see the bladder, and you see, here's the bladder, here's the rectum, and you can see this purple area here where the organ should have been, but there's no organ there, except for that rudimentary structure. So we then create the structure, put it in, and here's that same patient 6 months later, showing the rectum on the right, the bladder on the left, and their new engineered organ. And we followed these patients for 8 years. We followed these patients for 8 years after we did the clinical trial. We took small biopsies, and we followed them with doing endoscopy, yearly endoscopy, where these patients were investigated endoscopically, surgically, minimally invasively. We took biopsies yearly, where tissue samples were obtained yearly. We did histological analysis, we did molecular analysis, and we did functional analysis and yearly MRIs to show that these organs continue to do well over the 8 period. And many people asked us, and here's the functional testing showing that the patients continue to do well for the duration of the study. And we published that work in The Lancet in 2014. Now, many people asked us, why did you wait 8 years to publish this work? Mainly because when you look at the current strategies that are being used, where they use intestine to create these organs, or skin, which is being used to create these structures, they tend to fail by year 5. And there's a very, very high failure rate by year 5. So we wanted to make sure that we went way beyond the normal failure period of the other structures to show that these continue to do well, because these are the patient's own native tissue, and it's going to do well over time. So these patients continue to do well, and we're proceeding with the next phase of the trials. The first organ we implanted was actually the bladder, but I'm showing these in order of complexity, from flat to tubular to hollow non-tubular, less complex to more complex within each category. This was in fact the first organ we implanted, but same strategy. The strategy never changed. Now, we started with a level 3 organ, which was quite complex. If we had to do it all over again, we would never start with this particular organ. But we were naive at the time, but by going after this particular organ, it really made it very easy for us to go back to level 1 and level 2 organs, to flat and tubular structures. But same strategy here. We took a small sample of the tissue. We expanded the cells outside the body, muscle and epithelia. Once we had enough cells for the construct, about 4 weeks later, we started to seat the construct. We took the scaffold and the shape of the organ. We coated the inside with the lining cells, the outside with the muscle cells, put it back in the incubator, and then placed it back into the patient. We first did this preclinically, of course, with the small animal models, mice, rabbits, finally a canine model. And after the canine model, we went to the humans. We published our preclinical work in Nature Biotechnology, and we then ended up doing the clinical series. These were patients who had all failed medical therapy, were candidates for surgical reconstruction. We basically created imaging processes with our physicist at Children's Hospital of Boston, where we had this 3-dimensional organ, the bladder, but we needed to know that when we created the organ, that it was going to fit within the pelvic cavity. So we talked to our physicists, and they just basically helped us to reconstruct the 3-dimensional organization of these organs. And this is prior to current imaging techniques that you see commercially. So it was all done basically with the physicist at our hospital. And believe it or not, this is the precursor of what we now do with the printers, right, in terms of imaging for patients. But basically, this allowed us to create the structure the way we want it. You see here the AP and lateral view of these scaffolds. You can see here on the bottom left the engineered bladder that's been now implanted. So this is a scaffold alone on the top. On the bottom left, you see the engineered bladder being implanted surgically. It's covered with omentum for added vascularity. And this shows the preoperative picture of the bladder with an end-stage small contracted bladder, and then the bladder, the engineered bladder on the right. And this shows the pressures, because that's why we did these patients. They had very, very high bladder pressures, and when they reached a certain pressure that was too high, that starts to damage the kidneys. And that's what you see on the top panel. And then after we put the engineered bladder, you see the normal pressures that you would expect in a patient. Now, this is work that was presented by Dr. Alan Reddick, who was a surgeon-in-chief and head of urology at Children's Hospital and Harvard Medical School, showing that as these patients grew, these were implanted in children, and as these patients grew, so did the bladders. So the body recognized the organ as its own. And as the patient continued to grow, the organ grew with the patient. And phase 2 clinical trials were done, and what we learned from phase 2 clinical trials is that you really do need to cycle these organs. You have to allow them to fill and empty. You cannot defunctionalize them. And we published our initial series in The Lancet as well. These were patients who had, when we published the paper, we had over a 5-year follow-up on these patients, and this work is now proceeding, continues to proceed through the next phases of the clinical trials. By far, the most complex organs are the solid organs, because you have so many cells per centimeter than any organ, than any of the other tissues, flat, tubular, or hollow non-tubular structures. And thank you, Ari. One of the most complex vascular organs is actually the phallus, because it's really a large blood vessel, if you will, very, very vascular. And so I'm just going to show you the work that we published in the Proceedings of the National Academy of Sciences in 2010, because that pretty much sums up what we've done. But basically, here's a strategy. We take a very small piece of tissue from the structure, we grow and expand the cells outside the body, and we then take a donor corpora that we decellularize, and we then reseed. And this is really where we came up with the concept of using decellularized organs. This is really the study that did it. We started this work, believe it or not, in the early 1990s, and in 1994, that's a long time ago, 1994, we basically realized that we could not achieve the three-dimensional structure that we were looking for. So we could get the cells and we could lay them on scaffold systems, but we could not achieve that three-dimensional structure. And that's really what occurred to us. Why don't we just reuse discarded organs? Why don't we just reuse organs from cadavers that are not being used? So this was a strategy where we took the organ, we basically decellularized the structure, we took all the cells away using very mild detergents, and we could now reseed the structure using the cells. And that's how we did it, and this was the study that actually led us to this process. We, of course, did all the studies that I mentioned before. We did the cell biology studies, the mouse studies, the rabbit studies, partial replacement, full replacement, non-human primate models that we ended up doing. But this basically is a summary of this particular study, where you see that when we implanted the full organ, this is a full replacement of the organ, a total replacement, and you can see here the normal on the left, a normal control. On the top right, you see the engineered organ, and of course the controls without the cells did not do well. When we looked at the pressures, by 6 months, the pressures were sufficient for erection, penetration, copulation, and ejaculation. And we were able then to mate these animals with their female partners. We were able to obtain sperm from the vaginal vault of the partners, and this led to offspring, showing that in fact these organs were fully functional. And right now, this is in fact, we just got approved. This is of high interest to our military, because as you know, due to improvised explosive devices, pelvic injuries have become a major area of concern for the military. And so this work has been funded by the Department of Defense. And this year we're implanting the first engineered penile tissue for patients. This has already been approved by the FDA, has been approved by IRB, and we're currently recruiting patients to proceed with the first treatments. Other solid organs, the liver. Very early on, we started looking at other solid organs as well. So we started looking at the liver, and Shai did a lot of work through the liver. This is Minhaj Siddiqui, one of our Howard Hughes fellows who we had in Boston. Pedro Batista, who was a fellow who came to us from Portugal. He's now a faculty member back in Europe. But basically, same strategy here. Same exact strategy. We basically take the organ, a donor organ like the liver that's going to be discarded, and we then take the organ, we use very mild detergents to wash the cells, and 2 weeks later you're left with something that looks like a liver, you can hold it like a liver, it feels like a liver, but it has no cells. But you are able to preserve the blood vessel tree. And so this is a decellularized liver, and we're going to inject contrast, and you can see here that there are no cells here, but the skeleton of the organ has been preserved. You're able to inject the contrast and see the vasculature, and basically we published that work in the journal Hepatology, where we were able to engineer these structures by seeding them with the cells. So we perfuse the vascular structure using endothelial cells. We infiltrate the rest of the skeleton with the liver cells, and we're able to reproduce the human fetal liver structures that you see on the left we're able to reproduce with the bioengineered livers. We're able to mature them, where they secrete urea, they secrete albumin, and do a lot of the stuff that normal livers do. And we can make these right now about the size of a large lemon. But basically what we need is about the size of a football. So that's a lot of the work that's being done in the laboratory for this particular organ. About 15 years ago, we started looking at printing. And the reason we started looking at it was because we had already implanted tissues in patients. But we realized that we were, if we really, really wanted to expand this technology, we needed to automate the process because we were making these organs by hand, one at a time. And if you're making these organs by hand, one at a time, you have to really be careful with reproducibility. The cost is very high. It's just hard to produce. You had to automate the process. And that's really where we started looking at bioprinting. And initially, we just started using your typical desktop inkjet printer. And the concept was that we, instead of using ink, we used this hydrogel with cells, and we modified these desktop inkjet printers with a 3D elevator. So every time the print head would go through, the 3D elevator would lower itself, and you would just print layer after layer using this strategy. And this is work of Tao Zhu, who was one of the fellows in our lab, and we were able to print various types of structures, as you see here. And this is the actual printer, and you can see the printer going back and forth. And this printer is now, of course, retired. You can see it at the Museum of Health in Washington, D.C. at this point. But basically, it shows how crude the technology was, right? It's just a print head going back and forth, creating this two-dimensional structure, which is this miniature heart. And when basically we are able to take that miniature heart, it takes about 40 minutes to print. And then you can see the structure right there coming out of the 3D elevator. Here's a 3D printed structure. And we started to show that within 4 hours, it would start to beat. You could see it beating at first. It would start to beat erratically, then would start to beat in unison. And you hear the cardiomyocytes beating together that you see here, the muscle cells beating together. But unfortunately, we didn't have the structural integrity necessary to really implant these surgically. They could be printed, but they would basically, after a while, they didn't have the rigidity necessary for surgical implantation. So that's when we started working over a 12-year period. We started working on a more sophisticated printing system, which we call the Integrated Tissue and Organ Printing System, or the ITOP, which basically is a system that allows you to print these structures with the structural integrity necessary. And it has 5 features that make this printer increases the feasibility of printing tissues and organs. The first principle is that these are very, very small nozzles. They go all the way down to 2 microns. So that's about 1/80th the diameter of one human hair. So that's very small. The second, of course, for cells is about 15 microns, because cells are about 15 microns in diameter. The second feature is that these cells can really place the cells where you need them, right? Because you can really precisely place the cells where you need them. The third feature is we created these bioinks that allow the cells to go through the nozzle as a liquid, but when they leave the nozzle, you're able to cross-link them. So once they hit the platform, they retain its structural integrity. The fourth feature is that we were able to create these microchannels that would replicate, if you will, a sort of a vascular system that would promote a highway that would allow nutrition to go through to the central portion of the construct, allowing us to create larger structures. And finally, by doing this, we're able to create human-scale constructs. And the fifth feature was this imaging software that we designed. This is now TerraRecon. This is one of a commercial available program that is available in every major hospital where you do imaging and you can 3-dimensionally reconstruct that. So we basically use what's commercially available, but we designed our own software program to basically download that digital data into our own software program. And by downloading this digital data, we're then able to print the structure based specifically on that imaging system. And so those are the 5 features. We published that work in 2016. and we are proceeding with that work. And basically, just to say that the printers that are being developed here in Israel with laser are even more precise. That is even more sophisticated technology that's going to these printers. And this is our latest printer, which is a printer basically that is designed to print on the patient itself. So you bring the printer to the patient. So that here on the top left, you see the schematic of how the printer works. On the right, you see the actual printer. So with a scanner. So what happens is you have a scanner. You bring the printer to the patient. You scan the patient. Once you scan the patient, you're able then to bring that data digitally to the printer. And here's a pictorial video of how this works. You scan the area. That digital data is transferred to the printer, and then you're able to print the layers right where you need them. So this is another printing technology. And you can see here that we can print these structures, very sophisticated skin. For example, this is 3-layered skin with 7 different cell types. And so for more complex functional organs, by far the most complex solid organs are the ones that have high levels of functionality, like the kidney. And in fact, the kidney is the #1 organ in need. If you look at all transplantation, at all patients on the transplant wait list, over 80% of the patients on the transplant list are waiting for a kidney. So same strategy here. We started this work very early on. We were able to grow and expand these cells, normal cells. We were able to place them onto these structures, and we were able to implant these into cows and steer to show that we could create these kidney-like structures that were able to secrete this yellow fluid, which was approximated the conditions of concentrated urine. It was dilute urine in these experiments, and you can see if we did not use the cells, of course, or cells from another, it did not do well. So you need to have the autologous cells, right? The cells that will not reject. And this shows the actual constructs that we created. On the top left, you see what happens if we didn't have anything. On the top right, you see the proximal and distal tubules. On the bottom right, you see the glomeruli. On the left, you see what happens to glomeruli that's implanted in a non-autologous manner. And you can see the glomeruli, proximal tubule, loop of Henle, and distal tubules on the right of the engineered kidney. These engineered kidneys had erythropoietin levels and vitamin D3 levels consistent with renal structures. The retrieved renal tissue had molecular markers and genes, again, consistent with kidney tissue. And we published that work also in Nature Biotechnology. Successful transplantation of cloned cells, because we use cloned cells to create these structures. Where we are with this technology is that we currently have a technology where we're able to go to the patient, we retrieve a very small biopsy of the patient's own kidney, and this can be done on 70-year-old patients, 75-year-old patients and older, where you can just go in with an end-stage kidney failure structure. We can go in with a needle in a minimally invasive approach, take a biopsy of the kidney, isolate the committed progenitor cells, and then use a hydrogel to insert that back into the patient. This was done in a rodent model to show that we were able to rescue the kidneys in the rodent model. And on the far left, you see the 2 native kidney renal functional units. And then the hydrogel was placed in the center, and you can see all these new kidney units that are contributing to the kidney function in that particular organ. And this is now in clinical trials. Phase 1 clinical trials have been completed, and there are now phase 2 clinical trials in 10 centers in the U.S. with this technology for patients with end-stage kidney failure. And what the trials are showing is that once they receive these are patients who were on the decline in terms of their kidney function, and so they were going in this direction, and once they received the treatment, they stabilized and they were kept off any further progression of their kidney disease. We've also gone through other cell therapies. This is actually skeletal muscle. We have this for several different indications now. We've done this for example, for urinary incontinence, and we are now starting a trial for shoulder surgery in patients at Wake Forest. These are patients who've had shoulder surgery and then have atrophy of the muscle. and these cells are being placed in that area. And basically once you inject the muscles, place the muscle cells in there from the same patient. So we take the muscle cells from the patient, we expand them, we put them back into the patient. By doing this, we're able to inject these cells in the damaged region in the same patient, and these skeletal muscle cells, of course, have various applications throughout the body. And finally, to describe to you a little bit about stem cell therapy. Everything I've discussed to you thus far uses the patient's own cells. We take a biopsy from the patient, we expand the cells, we put them back into the patient. But what if you don't have that specific organ? You were not born with that organ, or you have one of these organs where you can't really grow the cells outside the body, like the nerve, for example, or the pancreas. What do you do then? That's where stem cells can come in handy. And up until recently, there have been 3 stem cell populations that have been used where you can that can give rise to different cell types. So basically, embryonic stem cells, human embryonic stem cells, and what more recently discovered, induced pluripotent stem cells, where you get the cells from the patient, but then you use genes to revert the cell back to a human embryonic stem cell state. These are the cell types that can in fact go into all 3 germ layers. And they reproduce very well, but unfortunately, as you know, they can form tumors. That's been the challenge with both human embryonic and iPS cells, right? They form tumors. And that's why you have seen such limited clinical application. On the other hand, you have adult bone marrow, cord blood, and fat, all these other stem cells that are really just progenitor cells, and they don't form the tumors, which is a big plus. And they can be used without rejection if you put them back into the same patient. But unfortunately, you cannot really expand these cells very well. They have a limited expansion potential, and furthermore, these cells cannot really go into all 3 germ layers readily. They can go into mesenchymal lineages, like for cartilage and bone, but they won't necessarily go into lineages such ectoderm and endoderm, such as liver or pancreas. So on the one hand, you have cells that are very powerful. They can turn into anything. They can grow rapidly, but they can form tumors. On the other hand, you have cells that will not form tumors, but you cannot grow readily and have limited potential to go into other cell types. So about 16 years ago, we started looking at alternate cells. And we had this thought that maybe, perhaps, there would be a cell population that we could isolate from both the amniotic fluid and the placenta. We knew that there were cell sources in the amniotic fluid and the placenta from the fetus, but we were really looking not for a mesenchymal cell, but a true stem cell that would go into all 3 germ layers. And that was really what we were looking for. And so we ended up doing experiments with amniotic fluid, which is the fluid that surrounds the developing baby in the womb, and chorionic villi, which is in fact the placenta, also from the developing baby. And we basically went on a fishing expedition. We were looking for a cell type that would have the characteristics of a true stem cell. And in fact, we were able to find it with the isolation of c-KIT, this one marker. We obtained cells from over 400 pregnancies, both amniotic fluid and placenta. And we were able to show that these cells could grow, expand rapidly, and could go into all 3 germ layers. They can go into mesenchymal lineages, endoderm lineages, and ectoderm lineages, just like human embryonic and iPS cells. In addition, they were clonal. That is, one cell would give rise to all 3 germ layers, just like human embryonic and iPS cells. And they had markers consistent with human embryonic stem cells and iPS cells as well, including OCT4 and SOX2, the master gene. But interestingly, they also had markers consistent with adult stem cells, and that's when we knew we had something different. In fact, when we looked at a stemness analysis, we saw that these cells were very, very closely related to human embryonic and iPS cells, but not as primitive, just slightly more developed. If you have human embryonic stem cells on one side, and you have adult stem cells on the other side, these cells were somewhere around here. These are iPS cells here. These cells were somewhere around here. Maybe it's hard to see my fingers, but slightly more developed than human embryonic and iPS cells. And they preserve the telomere length, just like human embryonic and iPS cells. But interestingly, this was a major difference. Unlike iPS and human embryonic stem cells, they did not form the tumors. And the reason for that is that the genes are there, but they're not as primitive. It's slightly more developed. So the cells did not form the tumors. And basically, like bone marrow and fat stem cells, they do have an anti-inflammatory response. So you're able to inhibit activation of T cells. And so the cells can be used in two ways. They can be used in an autologous manner, that's avoiding rejection, or they can be banked, and the bank can supply a large number of patients through the banking. Or you can use the cells in an anti-inflammatory way, but in a clonal manner, where you don't have to keep going back to the source or the donor to get the cells. We then started to look at the differentiation of these cells. So for example, here's SOX2. Here's a master differentiation stem cell gene. And you can see what happens when we start to drive these cells towards a cardiac or a heart phenotype. You can see SOX2 goes down to 0 within 10 days. And within that same time period, you can see here that it goes, cardiac troponin T goes up 1,200-fold. And showing that, and when you start to implant these cells, they start to beat. And this is work also that Shai Soccer was involved with through the Institute. And then here we were able to show that these cells could also go to a lung phenotype. This is work of our collaborators in California, showing that they could revert lung injury. And here's work from also from California, showing that they could revert kidney injury. So basically, these cells, you can derive them from the amniotic fluid or the placenta, either before or at the time of birth. The cells are neither embryonic nor adult, but have properties of both. They do not form the tumors, and they can be used without rejection. And unlike mesenchymal stem cells, you can also get mesenchymal cells from the amniotic fluid and the placenta. So you can also get mesenchymal cells from there. But unlike the mesenchymal cells, these cells are truly highly multipotent. They will go into all three germ layers, and as a consequence, they will expand in large quantities and not form the tumors, and they can be used for self-use or banked. No cell is perfect, and neither is this one. The weakness with the cell is that whereas with a human embryonic or an iPS cell, you can actually get these cells to form liver cells, for example, within a 7-day period. With these cells, it takes about 20 days. Because you have to drive it harder for it to get to where it needs to go. So, but that's also the same property that does not allow the tumors to form. And we published that work also in Nature Biotechnology back in 2007. So to summarize then, what I've tried to do for you today is really give you an overview of some of the work that we're doing in the area of regenerative medicine. We talked about using materials alone. And materials alone, again, can be used for small defects, less than 0.5 centimeter from any edge. We talked about using cells and materials together for larger defects. And we've done now that for basically many different types of tissues. We've talked about using cells alone. And we've talked about strategies for more complex organs, such as using discard organs or 3D printing. And we also talked about the complexity of the organs, with level 1 being the least complex, flat structures such as skin. Level 2 being the second level of complexity, tubular structures like blood vessels or windpipes. Level 3 being hollow non-tubular organs like the stomach or the bladder. And finally, level 4 being solid organs like the kidney or the liver. Up to this point, we've been able to apply technologies to all 4 levels. And the goal for us, we have about 10 different tissues now in patients entering our 10th tissue this year. I've discussed a few with you today, and our goal is to keep expanding the number of tissues that we can put into patients. And then to basically just emphasize that really this does require a multidisciplinary team. The reason why we're able to do a lot of this is because we really do have a multidisciplinary team. Cell biologists, molecular biologists, material scientists, all working together to bring these technologies from the bench to the bedside in a team approach. This is team science, bringing everybody together to bring these technologies to the forefront. And at this time, I'd like to acknowledge our team. Really, some of the best and brightest, just an absolutely amazing team working together towards our common goal. And this multidisciplinary team is what we try to reproduce with what's now called the Armed Forces Institute for Regenerative Medicine. This is now our 10th year through this program funded by the Department of Defense, where this is over $200 million investment from the Department of Defense to bring these technologies from the bench to the bedside for our wounded warriors. We currently have about 10 active clinical trials for our wounded warriors through this program, which is a national program led by our institute. I always like to show this cartoon. This is how to stop runaway stage. Method 1, the stagecoach driver goes A, B, C, D, F. He finally stops runaway stage. And those are usually the basic scientists. And method 2, those are usually the surgeons. Now, I'm a surgeon as well. But when it comes, I hope if anything today, I've underscored the fact that we follow method 1, right? Everything we've done has been very methodical. We do all the cell biology. We do all the material sciences. We do test these things extensively in the laboratory in vitro. We then go to animal studies. We do small animal studies. We do medium-sized animal studies. We do large animal studies. We then go into patients. We do it very slowly. And when we go into patients, we ask our team, our whole team, we ask a very simple question, which is, are you willing to do this in your own loved one? Are you willing to listen to your own child, your own spouse, your parents? And unless we all answer yes, we won't do it. And we've gone through all this work. It takes years to get to that point, right? We've done many animal studies, reproducible by many different hands. And then once we finally reach patients, we treat patients slowly and carefully with a long-term follow-up. All our studies I've shown you that have been clinical, we've waited until we had a 5-year follow-up before we publish the work, because you got to know the whole story of what happens, so you don't give patients false hope as well through the process. So methodically creating these technologies to make patients safe. At this time, I'd like to acknowledge our funding sources, which have made this work possible. And finally, to leave you with a very brief video clip of a patient who was treated with these technologies, one of these technologies, and this is an interview he gave 10 years after he received one of these technologies.
I was really sick. I could barely get out of bed. I was missing school. It was just miserable.
No, you can't hear it? Let me try that again.
I was really sick. I could barely get out of bed. I was missing school. Just pretty miserable. I couldn't, go out and play, basketball.
Can you hear it now?
I was really sick. I could barely get out of bed. I was missing school. It was just pretty much miserable. I couldn't, go out and play, basketball at recess without feeling like I was going to pass out when I got back inside. I felt so sick. I was facing basically a lifetime of dialysis, and I don't even like to think about what my life would be like if I was on that. So after the surgery, life got a lot better for me. I was able to do more things. I was able to wrestle in high school. I became the captain of the team, and that was great. I was able to be, a normal kid with my friends, and because they use my own cells to, build this bladder, it's going to be with me. I got it for life, so I'm all set.
So that's Lucas Masella. As I mentioned, that was 10 years after he received his engineered organ. The fact is that we still have ways to go. We have a lot to do. I want you to know that a lot of these technologies take a lot of work. Of course, I showed you everything that worked. I could fill up, basically, for everything that worked, I could show you 99 things that did not work. And the fact is that once we get to the patient, it's got to work, right? Once you get it to the patient, it has to work. And so that's really and that takes a lot of work and effort. So I don't want you walking away here thinking, boy, this stuff is easy. You just push a button and there's the organ, because nothing could be further from the truth. But these technologies do require a lot of work. We still have a lot of work to do to get more tissues into patients. But at the end of the day, the goal of these technologies is just one: to make patients' lives better. And that's where Regenerative comes in, and that's the goal. Thank you so much for your attention today. That's a great question. I just heard some of the amazing work that's been going on from Mr. Segol. So absolutely, I think that could be a very interesting intersection between regenerative medicine and hyperbaric chambers based on some of the stuff that I've heard. Thank you.